Okay, good morning and welcome to the Davies Use Case webinar being presented by Petaluma Health Center on hypertension control. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. Is promoting the use of health IT to improve the quality of healthcare delivery. The integration of clinical decision support and best practice guidance, access clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patients' outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes and the value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT-enabled care delivery. It is my pleasure to welcome our speakers for today. Dr. Danielle Oren is the Chief Medical Informatics Officer at Petaluma Health Center and Redwood Community Health Coalition, where she provides leadership for initiatives in clinical systems, health information technology, and quality improvement. Sean Nelson has worked for federally qualified health centers since 2010, where he's drawn to both the mission of the organization and the opportunity to use data to improve patient care and experience. Thank you both for joining us today. And over to you both.
Thank you. So we'll go ahead and get started with our use case. As Arnold said, we are from Petaluma Health Center, and I his slides. Hang on. Okay. Here we go. All right, here we are. So, a little bit to start around Petaluma Health Center. So, Petaluma Health Center was founded in 1996 as a community health center associated with the hospital in this town. Later in 2000, the health center became a federally qualified community health center. We currently care for about 29,000 patients and have about 150,000 annual visits across our two main sites, Petaluma Health Center and Rohnert Park Health Center, and our satellites that are open part-time, which include a homeless shelter and 3 school-based health centers. Our services are very broad spectrum. We are a community health center and focus on family-centered primary care for children, adults, and we have OB care and wellness services, including acupuncture, chiropractic care, integrative medicine, and some specialty care, including eye care, podiatry, and then endocrine care is provided via telehealth. Background before we get started speaking about our main topic, which is hypertension today, I think it's important to understand how our analytics infrastructure is set up. So we use eClinicalWorks EHR and Dentrix dental record. Those are completely separate health records that each feed into our data warehouse, for which we use a vendor called Relevant. They provide us with a front-end web-based application that our end users can use, and we also use Tableau to provide a second front end for management for things that are not included for our end users. So we'll be showing a little bit of that today. All right, so we're going to get what we've done in hypertension. The reason we chose to work on hypertension was because in our community, heart disease and stroke are a real problem. 25% of deaths in Sonoma County in 2013 were attributed to heart attacks and strokes, and more than the state average of adults in Sonoma County have heart disease. The percentage of patients with heart disease has been increasing rather than decreasing in the last few years. And the prevalence of high blood pressure in our county is higher than both state and national levels. And we know that controlling blood pressure reduces heart attacks and strokes. So this seemed like a rather urgent issue, and we have been working on this effort for quite some time. Here are hypertension control rate benchmarks that we compare ourselves with. So the California Other Health Centers, the National Other Health Centers, and then we look at our HEDIS benchmarks. And so our goal in this work was to decrease heart attacks and strokes in our population by improving control of high blood pressure. Successive initiatives. I wish I could say that there was one health IT-driven initiative that improved hypertension control, but the truth was that there were many, many successive initiatives, and I'm going to walk through some of those today, many of which were supported by technology. We did not implement any technology specifically for hypertension control, but rather use the technology that we already had in place throughout this, which included electronic health record, analytics, and customize those systems to help drive improvement in hypertension control. Walk through the initiatives that we had in order of how we think of the cycle of patient care. Coincidentally, this was also the order of initiatives that we had. So we're going to go through the changes that we made that affect the pre-visit huddle, the office visit time frame, which includes the time when patients come in to the appointment, and the things that we customized in the EHR and analytics there, and then what's going on outside the visit, and lastly, what happens when there's no visit planned, when patients are actually at their home, which is most of the time. So, and this was the order in which we tackled this problem, and so we'll walk through step by step through the changes that we made in each one. So starting with pre-visit, our health center has for a number of years used a standard clinical review process for alerts. So we have a standard huddle that happens every day before every shift where providers and MA teamlets review every single chart. And that systematic review consists of a clinical review. So the provider will say, who is this patient? What can I anticipate from what I know about them? What happened last visit? Things like that. And then the medical assistant records anything that's to be done on a list within the chart. And then we review the alerts. So we've customized our alerts in our EHR quite extensively. We review those alerts and record an agenda of which ones we're going to do today. And then after that, we merge documentation templates, and this is how we can ensure that our standard documentation templates are being used for chronic conditions. So that happens at Huddle. And then lastly, we try to anticipate needs from ancillary team members or services. So we have nutrition on site, behavioral health, and so that would be the time when we think about what this particular patient is coming in for and identify if they would be a good candidate to see one of those ancillary providers to assist them with any of their medical problems. But in this case, we're talking about hypertension control. And if that is identified, the patient is seen that same day by that individual. So to go through some of the customizations in the EHR, and this was some very early on work, we, because we review all of the alerts, one of the alerts that we had set up and customized was for any patient whose blood pressure was 140 over 90 last visit, it gets alerted at Huddle, and so we can make an appropriate plan for when they're coming in. Here we have a saved slot in our schedule called Team Huddle, and that takes the first 15 minutes of every shift. So you'll see there's one in the morning and one in the afternoon, and if we were displaying an evening, there would be one in the evening as well. So the next area we began working on was around what the processes that happen during the office visit. So that included blood pressure measurement, how the MAs collect blood pressure, how they actually take blood pressure, and standard guidelines which lead to a standard template, a documentation template, and a standard order set. So we began working with one of our care teams. At the time, we had 3 care teams. Now we have 5. But we began working with one of our care teams who decided to champion this project. And the first thing that they did was decide that there should be a standard measurement protocol. So we instituted a standard protocol for our medical assistants, taking blood pressure after 5 minutes, seated, and then if it's still high and the person's over 70, they have them stand up. So a whole very standard way of teaching. And that was incorporated eventually into our training for medical assistants for the entire organization. And then to support that on the health IT side, we also used that opportunity to train on where the blood pressure is actually recorded. And so we use a best blood pressure field, and we make sure that that is the one that's recorded, and then we have a secondary blood pressure field to record other blood pressures that are taken during the visit. During that time, we're working with our Community Health Center Coalition, which is in our region. There's a coalition of 17 community health centers that work together on some quality improvement projects. And together we adopted a hypertension control guideline. And so that was done kind of outside of us. And once that guideline was adopted, we conducted some training for providers and nurses that improved buy-in from both groups. And that allowed us, using that guideline, to create a standard documentation template and order set. And having that standard documentation allowed us to have nurse co-visits. So a nurse co-visit, for which is probably familiar to many health center viewers, is where the nurse may start the visit and really complete most of the visit, but it's physically supervised by a provider stepping in, reviewing the case, answering any last questions. So it's a very brief visit with a medical provider, but an extensive visit with the nurse. And so having these standards has allowed us to have these kinds of visits for patients, which has improved access. So as you can see here, we have one field where the best blood pressure is recorded. And if the blood pressure is abnormal, it comes up in red. And those were both customizations in the very early work. This is our hypertension guideline, and we're not seeing the whole thing, but as you can see here, it's pretty simple. We adopted this as part of the Kaiser Preventing Heart Attacks and Strokes Every Day program. They were generous enough to share this guideline with the whole coalition, and we've adopted it, and it works very well for us. So what we did was we took that and we created a documentation template that includes reminders for what are the blood pressure goals, what are important elements of a blood pressure visit, and that reflects the medications on our hypertension guideline. It also includes the guideline itself and any labs that need to be ordered. We also include some patient education materials, and these being used satisfies meaningful use requirements as well. So it's a double good for us. The next area that we worked on was working on what happens outside the visit for blood pressure control. So our internal quality improvement has implemented technology-based recall systems. So what we do, instead of our old way, which was sending letters, this is the health IT-enabled way, is we send automated voice messages, text messages, emails, and app notifications via portal to patients whose last blood pressure was over 140/90, or patients who have a blood pressure diagnosis on their problem list but have not had a visit in 6 months. And we send those messages urging them to come in for a follow-up or give us a call. The screen showing the protocols that we use. So patients who have a last blood pressure uncontrolled or no visit, and you can see that we have some control over customizing these campaigns. So we're reaching out to both genders. We control what age group. In our system, we only want to send out automated phone calls on Tuesday, Wednesday, and Thursday because we have a lot of phone calls on the other days, and how often patients are followed up. Here is a graph of those uncontrolled blood pressure recall messages sent. So you can see by day how many messages were sent. Because they're rolling, we don't get that mass kind of messaging that we used to get in our prior systems. So this has been quite successful in terms of getting our patients back in when they're due to come in. Okay. Last piece that we did before we share some of our results with you is that got us a lot of improvement, just the 3 first steps, but we struggled for a long time to really make it to our goal, which was 75% of patients with high blood pressure being controlled. And what we did that ended up putting us over the top was having our care teams monitor their performance using Relevant, our analytics product, and every patient with uncontrolled blood pressure at minimum every 2 months, and make an individualized treatment plan for each patient. We also that's also included in our quality improvement plan, and providers are incentivized individually as such as well. So once a month, our care teams would they have time set aside during their team meeting to open up the analytics platform, the web-based tool, take a look at their patients, and make an individualized plan for each one. And we implemented that. This was our most recent intervention in hypertension in spring of 2016. it is available, that analytics platform is available to all team members. So we give a login to everybody who has a login to the EHR at this point. So it's very transparent, and they can access it at any time, but we also set aside time for it. So I'm going to turn it over to Sean to review some of the data.
Thanks, Danielle. So what you're seeing here is a screenshot of our web-based analytics tool, Relevant. Danielle did a really nice job of describing how thoughtful we try to be when we put data into our EHR and really use our EHR to its full capacity. And now we're going to talk a little bit about how we pull data out of that EHR and give it and really put it in the hands of our team members and give them time that we set aside to really manage this patient population. So this is a screenshot of our hypertension control measure. In the upper left-hand corner, you see our overall percentage of hypertension control, and you see a numerator and a denominator. And this is for our entire organization. So the denominator tells us that we have, a little over 2,800 patients with hypertension who meet for us, our UDS definition for hypertension control, that particular measure. And then 2,100 of that 2,800 had that under control, which means less than 140/90 by our definition, for an overall percentage of 76%. Now, this very clean user interface also allows team members to drill down. So you'll see on this next slide that we could just select one provider in particular and see that that provider actually has a hypertension control percentage of 85%. And now the denominator has gone down to 66, and the numerator is 56. And you can see this person works on a particular team. We could also drill down by provider team. We can look at things like insurance, race, ethnicity. This tool really allows us to drill down and look at it at a very granular level. If you'll advance to the next slide, you can see now this has all been blurred out to protect the patients. But this gives you a sense of what the drill down capabilities are. So when we do give the teams time set aside each month to manage their populations and really drill down to their care team level, they can then see not only who the provider is, but there's a tab system in the back. And right now you can see that we're selecting just the non-compliant patients. So while we can look at all of the provider's patients, we're really at this point interested in patients that have a blood pressure that's out of control. So we're looking at the non-compliant tab. You can see that the measurement values are all patients whose most recent blood pressure measurement was greater than 140/90. And the teams then use this to manage those populations and come up with individualized plans for these patients. So really there are two things going on here with this tool that we're very excited about. One is that we give them all access to this tool and really put this information into their hands. But number two, we have to also give them that time set aside to manage this patient population.
Great.
And so we've departed briefly from that hypertension control measure, and now we're looking at a measure called PHASE, which stands for Preventing Heart Attacks and Strokes Every Day. We're here trying to look at certain patients who meet eligibility requirements for this program that are on an aspirin, an ACE-ARB, and a statin. And as you can see here for this particular measure, it not only tells, in the previous measure we looked at hypertension control and it showed the measurement value. Here it tells them if they're on an aspirin, what that aspirin is, ACE-ARB, what that is, and if they're on a statin, what that is, which again just really gives the team members more powerful tools to improve patient care. So now we've gone back to the hypertension control measure, and we just want to show you our success when we've sort of implemented this tool and also given teams time, once a month or maybe every other month to really focus on this patient population. The improvement has been quite dramatic over time.
Great. Just a quick note around our financial benefit from achieving better hypertension control. So we participate in a quality improvement program with our local managed Medicaid, which is Partnership Health Plan, and we can attribute $60,000 of that quality improvement funds for the last 2 years for control, good control of high blood pressure. We also have been award recipients from HRSA, which gives out annual quality improvement awards for meeting particular combinations of benchmarks, and we can attribute about 20,000 of that to we also received grant funding for a project called Preventing Heart Attacks and Strokes Every Day through Kaiser, which has contributed as well for a total financial benefit of $113,000 in the last 2 years. And we anticipate much of that quality improvement award money to be recurring. Our outcomes and lessons learned here, just to add a little bit more before we finish up, is we've had improved satisfaction from providers and nurses because of co-management of patients. Patients have given positive feedback. They have enjoyed the improved ability to get an appointment, and by having a follow-up with a nurse, it's much faster, much less waiting. Patients have appreciated the reminders to come in for follow-up, so there's not this you need to remember kind of a thing. Our medical assistants are very engaged in working with the patients. In all of our work, they have had a lot of education around blood pressure management, and just looking at the data and making plans with their provider. They've become much more comfortable talking to patients about blood pressure, and they really like doing that work. They are now educating people on blood pressure control ranges and helping patients to set self-management goals around the management of their blood pressure. Importance and benefits of clinical standardization. So adopting a guideline and practicing in a similar or same fashion has really benefited us because we can leverage that to do so much more with our care teams. One challenge that we've had, and I think that these initiatives in succession have really helped us to kind of get through, has been spreading initiatives that work on one care team to others. Always a challenge in a larger organization, but I think the success that we had with these strong that it really did help us to work through some of that problem, and we've used that model, the same model that we've used on hypertension, to manage other quality initiatives as well. And then lastly, but definitely one of the very most important lessons here was providing real-time and transparent, usable data to our, putting it actually in the hands of our care team, and then giving them the time to actually look at that and manage it has resulted in tremendous improvement. And I think that has been our key takeaway from these initiatives.
Well, Danielle and Sean for joining us for this Davies webinar. Just let me change our roles here. More webinars and information on how to apply for the Davies Award can be found posted at the HIMSS Davies Awards website at hims.org/Davies. Thank you again, and have a great day.